My name is Dr. Richard Pratley. I'm adjunct professor of medicine at Sanford Burnham Prebys. I direct the Florida Hospital Diabetes Institute here in Orlando, Florida. You probably are most familiar with Orlando because of Walt Disney World. And I also do clinical research in diabetes here in Orlando. I've worked in the area of DPP-4 inhibitors for a number of years, and that's going to be our topic for this evening's talk. Our topic today is differentiating among the DPP-4 inhibitors with a focus on linagliptin. I've already told you where I come from, but to put it a little bit more graphically, on the left lower picture is a picture of our hospital. It's actually just the cardiovascular tower. We're a relatively big hospital in the United States, 2,700 beds. We're actually the largest hospital in the United States, although it's not terribly broadly known, in part because it keeps kind of a low profile. The middle picture there is a picture of our Diabetes Institute. We have 8 endocrinologists, 14 mid-level providers. We see about 35,000 patient visits a year. I know that that's just a busy day for many of your practices. The middle picture there is a picture of our Translational Research Institute, where I spend much of my days. In this unit, we do clinical research with new drugs for the treatment of diabetes, obesity, and metabolism. We do basic studies, NIH-funded studies, and we have about 100 people working in diabetes research, all of which has been put together in the last 4 years. And then the final picture on the right-hand side is Sanford Burnham. This is a basic biomedical research. We do mainly work in preclinical models of diabetes, obesity, and metabolism. But I want to make it clear that we don't study Mickey Mouse at this unit. Can I have the next slide, please? So our outline for this evening, I want to talk a little bit about the rationale for incretin therapy in type 2 diabetes. Then we're going to focus in on the pharmacology of linagliptin, one of the DPP-4 inhibitors, talk about the efficacy of linagliptin, and finally we'll talk a little bit about the safety of linagliptin. So, if we could have the next slide, please. Well, this slide demonstrates the prevalence of diabetes in various countries, and I know that congratulations are not in order for being the second in line behind China for the number of people with diabetes. I think the main point is that for all of our countries, diabetes represents a huge problem, a huge public health challenge because of the large number of people that are affected. As clinicians, we need to find out the best, most cost-effective ways to treat people to reduce the complications of diabetes, because that really is what drives most of the costs and morbidity and mortality associated with diabetes. We're fortunate in many ways that we have many fine drugs for the treatment of diabetes. Our challenge, of course, is to figure out how to use these in which patients at what time. May I have the next slide, please? So I always like to start with a very basic discussion of what type 2 diabetes is. I know that you're all experts in the field, but I want to emphasize that type 2 diabetes is in fact a pretty complicated disorder. It's complicated because there are multiple metabolic abnormalities that contribute to hyperglycemia in type 2 diabetes. Now, in my mind, I kind of group these into 2 major categories. Those that are primary, and by that I mean they precede and predict the development of diabetes. And then those that are secondary, and these may be secondary to the worsening metabolic milieu, the hyperglycemia, or the insulin resistance and beta cell defect. These include things like hepatic glucose overproduction, perhaps the incretin defect itself, and then the renal glucose absorption abnormality. The other key thing that people understand, I guess, is that this is a dynamic process. So what you see at various stages of the development of diabetes depends upon where people are in the course of diabetes. And the people have different trajectories. Some people progress relatively rapidly, and other people don't progress so rapidly. So keep in mind that there are multiple metabolic abnormalities. It's a progressive disease, and that the features change with the progression of diabetes. Next slide, please. Now, I'd like to show these couple of slides, which are from my early work with the National Institutes of Health when I worked with the Pima Indians in Phoenix, Arizona. These are kind of the seminal slides that help us understand the pathophysiology of type 2 diabetes as it relates to insulin resistance and insulin secretory defects. In this study, in the Pima Indians who have a high prevalence of diabetes, we were studying why people get diabetes. We brought them into our clinical research center every year. We did glucose clamps to measure their insulin sensitivity, and we did intravenous glucose tolerance tests to measure insulin secretion. So in these two graphs, you see insulin action, or the M value, on the x-axis, and insulin secretion on the y-axis. Turn your attention to the left-hand panel. This is cross-sectional data from about 400 people with normal glucose tolerance and then varying degrees of glucose abnormalities. The green curve, which is kind of a hyperbolic curve, describes the normal relationship between insulin sensitivity and insulin secretion. So you can see that as people become more insulin sensitive and move sort of to the right hand of the curve, insulin secretion is lower. But as they become more insulin resistant, there is a compensatory increase in insulin secretion, and that gives us this hyperbolic curve. Now, if we look at the mean data in people that have impaired glucose tolerance, impaired fasting glucose levels, or even diabetes there in red, we can see that these folks fall off of this normative curve. They may have the same degree of insulin secretion as the normal glucose tolerant people, but relative to their degree of insulin resistance, which is shifted leftwards, they have an insulin secretory defect. Now, because we brought people back longitudinally, we had the opportunity to study people over time, and took a cohort of people that had initially normal glucose tolerance, studied them again when they had impaired glucose tolerance, and studied them a third time when they had developed diabetes. And their curve is in the yellow and red there on the right-hand panel. On the right-hand panel, that green curve is that same normative curve for people with normal glucose tolerance. And you can see a curve with another group of people that were studied over the same period of time who maintained normal glucose tolerance. Now, both of these groups developed insulin resistance because they gained weight over time, and they had about the same degree of insulin resistance over the period of observation. The people that maintained normal glucose tolerance had a compensatory increase in insulin secretion. So you can see they stayed exactly on that normative curve. In contrast, the people that developed diabetes started off the curve. They were already insulin resistant, and then insulin secretion decreased markedly with the development of impaired glucose tolerance and then diabetes. And by the time people developed diabetes, insulin secretion was only about 20% or so of what it was in the normal group. So this highlights a couple of things. One is that both insulin resistance and insulin secretion are important in the pathogenesis of type 2 diabetes, and both of these actually precede and predict the development of diabetes. So in my mind, they are primary abnormalities. Let's go to the next slide, please. But we know that there are multiple other metabolic abnormalities if you look at people with established diabetes. In addition to the decrease in insulin secretion and the insulin resistance, there are abnormalities in alpha cell function with increased glucagon secretion. There's increased hepatic glucose production, which we actually studied and did not predict the development of diabetes. It is clearly present when diabetes is already developed, however. There's the decreased incretin effect, which we will be talking about later on. There are abnormalities in adipose tissue lipolysis, and there are even abnormalities in renal function with increased glucose reabsorption. These were all summarized nicely by Dr. Ralph DeFranzo in his Banting lecture published in Diabetes in 2009. So for the next few slides, we're really going to focus on the incretin defect. Can I have the next slide, please? And the next one, please. Thank you. You all have probably seen this famous slide before. This is a study done by Michael Nauk, my friend from Germany. And what he did was to assess the incretin effect in patients who had normal glucose tolerance on the left-hand panel and people with diabetes on the right-hand panel. What you notice is that the incretin effect, that area that's shaded in green, is much less in the patients with diabetes than it is in the patients with normal glucose tolerance. So this is the clearest demonstration of this impairment in the incretin effect. It's basically the difference in insulin secretion that you see in response to an intravenous versus an oral glucose challenge. This difference, known as the incretin effect, is what's abnormal in patients with diabetes. Next slide, please. Now, we know from many studies that the incretin effect is mediated by two enteroendocrine hormones, GLP-1 and GIP. These are secreted from cells of the gut, the L cells and the K cells respectively, in response to nutrient challenges. They circulate, but they also may have local effects on the gut. And collectively, they augment insulin secretion in the beta cell in a glucose-dependent manner. So they interact with a very specific receptor. There is a receptor for GLP-1. There's a second receptor for GIP. They are both coupled to cyclic AMP generation, and through pKa and EPAC, they augment the signal of glucose to enhance insulin secretion. So that's what I mean by the glucose-dependent manner. In the absence of a glucometabolic effect to stimulate insulin secretion, these hormones have no effect to increase insulin secretion. So that as glucose levels are low, insulin secretion mediated by the incretin hormones is turned off. Next slide, please. We think that the incretin defect in patients with diabetes is in part because of downregulated receptors for the GLP and, more importantly, the GIP receptor. This is shown in this slide. This is actually rodent work in which the animals were made diabetic with a sham operation or with a partial pancreatectomy. You can see in the setting of a partial pancreatectomy in which they get hyperglycemic that on the top panel there's marked downregulation of that green staining representing the GIP receptor. Now, if you correct that hyperglycemia with fluorescein, which is like an SGLT2 inhibitor, then you can restore much of the expression of the incretin receptor. The GLP-1 receptor is in the red, it's on the bottom panel, so you can see that there is some change, but not as marked change in the expression of the receptor. So the key finding here is that the regulation of these receptors seems to be regulated by hyperglycemia, and that could explain why the incretin response is diminished in patients with diabetes. Next slide, please. Now that's shown on this slide, also a study by Michael Nauk, and he describes this in casual conversations as just almost miraculous. He was doing these studies in the room with a patient, infusing GLP-1 for the first time. This study is designed to take patients with poorly controlled diabetes. Their fasting glucose levels were in excess of 200 milligrams per deciliter. And one day they got a saline infusion, which is shown in white, and then the second day, shown in yellow, they got a GLP-1 infusion. And Michael says, you know, it was just like seeing magic, because on the GLP-1 infusion days, the glucose levels dropped. And they didn't just drop, as you can see on the left-hand panel, but they actually normalized. So this is unlike any other diabetes drug that we have. Now, the middle panel there is insulin secretion, is indexed by the C-peptide levels. You can see nothing, of course, happens with the saline infusion, but with the GLP-1 infusion, there's this prompt increase in insulin secretion. And then towards the end of the 4-hour infusion, it drops off a little bit. On the right-hand panel is the glucagon levels. Again, not much happens with the saline infusion, but with the GLP-1 infusion, there's this prompt suppression of glucagon secretion. And again, at the end of 4 hours, this kind of returns back to baseline. Now, many people look at these curves and say, well, you know, this does suggest that GLP-1 is effective, but evidently there's tachyphylaxis. The effect seems to wear off pretty rapidly within hours. So, you know, this couldn't possibly be a good thing long term. But that's not actually the correct interpretation of these slides, these figures. What this is really showing us is that as the glucose levels come down into the normal range, the glucose-dependent effects on insulin secretion and on glucagon secretion from the alpha cell decrease the insulin secretion and increase the glucagon secretion back to normal. So essentially, we're restoring normal physiology with this GLP-1 secretion. When the glucose levels are low, you don't want a lot of insulin secretion, and you do want the protective effects of glucagon to help prevent hypoglycemia. Next slide. So GLP-1, in addition to addressing this incretin effect and having effects on insulin secretion, as I've already just showed you. So in addition to the effects on the islets with the beta cell and alpha cell effects, there's suppression of hepatic glucose production and enhancement of insulin sensitivity in the periphery. You can even argue that GLP-1 has effects on the neurotransmitter dysfunction through its effects on appetite. So just summarizing now the incretin defect in type 2 diabetes that we've just talked about. It's a pretty substantial impairment. It amounts to about 25 to 40% in different studies of the normal response. Many studies have indicated that it's not due to impaired secretion of GLP-1 or GIP, but it's probably due to the absent insulinotropic effect. This is clearly true for GIP because there's GIP receptor downregulation. And there's also a decreased response to GLP-1, but this can be overcome with higher than physiologic GLP-1 levels, as I've just shown you. GLP-1 infusions then at pharmacologic levels can achieve effective enhancement of insulin secretion, suppression of glucagon, and this lowers glucose in a glucose-dependent fashion. Next slide, please. So let's move on now to considering a rationale for using incretin therapies in the treatment of type 2 diabetes. We've seen that incretins play a key role in the early, in maintaining glucose homeostasis. Oops. I've lost my feed on this end. We've seen that the incretin effects are diminished in patients with type 2 diabetes by at least 60 to 80%. And incretin-based therapies, therefore, could target the multiple defects in type 2 diabetes as we've seen through GLP-1. And because of the glucose dependency, don't cause hypoglycemia and in fact have favorable effects on body weight. Next slide, please. Now, there are two different ways to target the incretin system. One is to use GLP-1 analogs that have a longer half-life. The problem with natural GLP-1, of course, is that the half-life in vivo is only about 2 minutes or so because it's rapidly inactivated by the enzyme DPP-4, which is present on cell surfaces and also circulates. So we can create GLP-1 analogs that are resistant to the effects of DPP-4. These are peptide hormones and are injectable. This is the exendin-based class of drugs, exenatide, lixisenatide, and so on, or a human GLP-1 based class such as liraglutide, albiglutide, dulaglutide, and others. The other approach, of course, is to block DPP-4, which is the enzyme that degrades GLP-1 and GIP. These are small molecules, they're oral agents, readily bioavailable, and we have probably 6 or 7 now available throughout the world. The most frequently used ones are sitagliptin, saxagliptin, linagliptin, allogliptin, and vildagliptin throughout the world. And we'll talk more about linagliptin because this is a relatively newer treatment, and in some ways it's differentiated from the other DPP-4 inhibitors, which is what I kind of want to highlight today. Next slide, please. Well, I know that you have your own guidelines for the management of diabetes in India that are evidence-based. Here are the ADA EASD position statement for managing hyperglycemia in type 2 diabetes. And I highlight in the red circle there just that, if you can click on it one more time there, that DPP-4 inhibitors can be used as second-line therapy after metformin. And they can also be used in triple drug combinations, in combinations with metformin, sulfonylureas, TZDs, and even with insulin. So DPP-4 inhibitors are squarely in our treatment algorithm for managing type 2 diabetes. Next slide. So now I'm going to move on to a consideration of the pharmacology of linagliptin in comparison to the other DPP-4 inhibitors. Next slide, please. This slide shows the structures of sitagliptin, vildagliptin, saxagliptin, alogliptin, and linagliptin on the right-hand side. If you just go ahead and hit it one more time there. We'll highlight linagliptin, please. That's good. And the good news is that there's not going to be a test on these structures, so if you're taking notes, don't worry about that. Two main points that I want to highlight. These are drugs from different classes of molecules. So the vildagliptin and saxagliptin molecules are cyanopyrrolidines. Linagliptin is quite different. It's a xanthine derivative. Linagliptin is actually also the most potent DPP-4 inhibitor. That's shown on that third row there, the DPP-4 activity. And then finally, the half-life of linagliptin is longer than any of the other DPP-4 inhibitors. They're all pretty long half-life, all suitable for once-daily treatment. But the half-life of linagliptin is extraordinary. It's 113 to 130 hours. Next slide, please. And hit the advance one more time, please. So the other thing that I want to point out is that there are differences in metabolism of the DPP-4 inhibitors. So sitagliptin, vildagliptin, saxagliptin, and alogliptin all have some degree of clearance by the kidneys. And therefore, it's important to adjust the dose of these drugs in patients who have chronic kidney disease to avoid high levels of the drugs. In contrast, linagliptin is partially metabolized, but a great deal of it is actually secreted unchanged in the bile. Therefore, it's not affected by chronic kidney disease and does not have to have dose adjustment in the setting of chronic kidney disease. There's just one dose for linagliptin, which is 5 milligrams. Next slide, please. It's important to study drug-drug interactions anytime you bring a new pharmaceutical agent to the market, and this has been done with linagliptin as it has with the other DPP-4 inhibitors. And as a class, these drugs are very well designed. By that I mean they really don't have a lot of drug-drug interactions that we need to worry about. And that's certainly true of linagliptin as well. Linagliptin, you don't have to adjust the dose with substrates of CYP3A4 or other drugs. Strong inducers of CYP3A4, because it's one of the metabolic pathways, could lower linagliptin levels. So it's kind of important to keep drugs like rifampin in mind and potentially use an alternative if they're going to be necessary. And food doesn't make any difference to the absorption of linagliptin. That's also true for the other DPP-4 inhibitors. Can I have the next slide, please? Well, this slide highlights the mechanism of action of DPP-4 inhibitors, just as a reminder. So when we eat, there's prompt secretion of GLP-1 and GIP into the circulation, and it's rapidly inactivated by DPP-4. So you can go ahead and just kind of forward through the animation. Now, in the context of a DPP-4 inhibitor, this blocks the activity of DPP-4, and we get more active GLP-1 and less of the inactive GLP-1 and GIP. Go ahead. And this, in turn, augments the incretin effects, which are insulin secretion, hepatic glucose production suppression, and increased glucose disposal. Next slide, please. This slide simply demonstrates that this mechanism of action holds true for linagliptin. In the upper right-hand panel, you can see that after a meal, there's a prompt increase in GLP-1 secretion, but levels of fasting GLP-1, active GLP-1, as well as the levels after a meal, are about 2 to 3-fold higher when linagliptin is on board, and that's the dark circles. In the upper left-hand panel, this results in lower glucose excursions after each meal over a 24-hour period. There's also an increase in active GIP, That's shown in the lower left-hand panel. And there's suppression of glucagon, which is shown in the lower right-hand panel. Again, the patients on linagliptin are in the dark filled-in line. So, in fact, the DPP-4 inhibitors do have the activity that we think that they should, based upon the mechanism of action, to enhance GLP-1 and GIP, suppress glucagon, and improve glucose levels. Next slide, please. So we're going to move on now in the next few slides to talk about the efficacy of linagliptin. So if we could have that next slide, please. Now this slide is a summary of the efficacy of linagliptin as monotherapy and combination therapy. Linagliptin is the yellow bar, and monotherapy studies on the far left-hand panel. The middle panel is initial combination with pioglitazone. The middle panel to the right is linagliptin as add-on to metformin, and the panel to the very far right is linagliptin added on to metformin and the sulfonylurea. So the main takeaway message here is that the efficacy of linagliptin is quite similar to the other DPP-4 inhibitors. And you would actually expect this based upon the inhibition of DPP-4. You get what you get from enhancing active GLP-1 inhibiting DPP-4, and all of the drugs are potent DPP-4 inhibitors. So the efficacy is therefore very similar across all of these drugs. There haven't been many head-to-head trials, but those trials that have been performed have shown identical efficacy. So the main A1C lowering is on the order of 0.6, a little bit more in combination therapy, of course, with pioglitazone. Next slide, please. Now, our perception of the DPP-4 inhibitors has been that they have modest efficacy. But in fact, if we compare DPP-4 inhibitors to a more traditional drug like a sulfonylurea, and there have now been 5 of these studies that have gone at least 1 year and up to 2 years, then we'll see a different picture. It's true that initially the sulfonylurea will be a little more efficacious. This is true from about 16 to 26 weeks or so. These are the line in open circles. This was a comparison of glimepiride, the sulfonylurea, and linagliptin. But rapidly, these lines converge, and you can see that for the majority of time, the efficacy of the DPP-4 inhibitor is identical, if not even a little bit better at the end of 2 years, to the sulfonylurea. So it looks like the DPP-4 inhibitors have very good efficacy, but they have perhaps a little bit more sustainability than the sulfonylureas, which we know lose efficacy after about the first 6 months or so. Next slide, please. This slide demonstrates the efficacy of linagliptin and metformin as initial combination therapy. Now, both the American Diabetes Association and the American College of Clinical Endocrinologists, or ACE, suggest that initial combination therapy might be appropriate in people who have higher glucose levels. These two groups differ in terms of their target for those higher glucose levels. And the ACE guidelines suggest that anything over 7.5%, you should start with combination therapy. The ADA guidelines are far more conservative, and they suggest that you might want to start combination therapy if the A1C is above 9%. But regardless, there have been a large number of studies of initial combination therapy, and we know that it's a very effective way to get people rapidly to goal. This is shown with the combination of linagliptin and metformin in this particular study. You can see that over 14 weeks, there was a reduction in hemoglobin A1C of about 1% with linagliptin and low-dose metformin, only 1,000 milligrams, which was equivalent to the high-dose metformin, the other line. This is important because we know that many people can't tolerate higher doses of metformin, and we can get equivalent efficacy with the combination therapy. We also see on the right-hand panel that there's a prompt reduction in fasting glucose levels with both treatments, and that's sustained for the short durations of the study. Next slide, please. Now, there's a sub-analysis of this study. This is a study of linagliptin and metformin on A1C in Indian patients with type 2 diabetes. I think there were about 250 patients in this study, and the data are identical to the data for the larger study. Small doses of linagliptin and metformin together did quite well, and they did as well, if not better, than the larger doses of metformin. So in the Indian population, this combination of metformin and a DPP-4 inhibitor is particularly well tolerated and efficacious. Next slide, please. Now, in that first slide of efficacy, I showed you A1C reduction with linagliptin and pioglitazone, and I wanted to come back to that study and give you a little bit more detail. So this was a factorial design study in which linagliptin was studied with pioglitazone. So one dose of linagliptin, 3 different doses of pioglitazone, and then the combination of linagliptin with the 3 different doses of pioglitazone. Fairly large study, almost 1,000 patients. Their initial exposure was for 30 weeks, and then they were followed for an additional 54 weeks. And the people on the low dose pioglitazone were then titrated to a higher dose combination or single dose therapy. If I could have the next slide with the efficacy, please. So this rather complicated slide with the multiple bars demonstrates the reductions in A1C on the left-hand panel and fasting glucose levels on the right-hand panel. And what you can see is that pioglitazone in the gray was quite efficacious at lowering A1C at the different doses. Perhaps a little bit more efficacious in this study than linagliptin, but other studies haven't shown a big difference. Linagliptin is in orange. But the combination drug in the light blue, medium blue, and dark blue was clearly more efficacious in reducing A1C by about 1.5% or so. And that's pretty good, starting from A1C in the low 8s. So very efficacious combination, working through a different mechanism of action than metformin in combination with linagliptin, which we saw in the previous slides. Next slide, please. Now, we've covered efficacy. We should certainly talk about the safety and tolerability of the DPP-4 inhibitors. I guess if I had to make a general statement, I think one of the features that defines the DPP-4 class is their overall tolerability and safety. Most people have no complications or no side effects from taking DPP-4 inhibitors. And the number of people that have substantive adverse events is really very rare with this class of drugs. And I think that's one of the great features for our patients. We can be assured when we're putting people on these drugs that they're going to be well tolerated and safe. Of course, in any clinical trials, we collect adverse events, and there really are no significant difference in adverse events in linagliptin compared to placebo-treated patients in most trials. Slightly higher rates of nasopharyngitis, but not significantly so, 7 versus 6.1%. And I really don't believe this is a specific finding for DPP-4 inhibitors. If you look back at the early studies with TZDs and even a drug called teglanide, there are also higher rates of nasopharyngitis in the active drug treatment. So there's something funny, perhaps, about treating diabetes, but I don't think it's specific for the DPP-4 mechanism. Really no difference in rates of diarrhea or cough or other side effects, and no difference in severe side effects. So if we could have the next slide, please. Who then is the ideal patient for DPP-4 inhibitor therapy? Well, certainly people who are metformin intolerant, people who have weight issues. These may be people that are concerned about weight gain with a TZD or sulfonylurea, for example. People who are at high risk for hypoglycemia, including our elderly population, or people with chronic kidney disease. This is an important subsegment of patients with type 2 diabetes. They're quite common, and we really don't have good evidence for the treatment targets in patients with CKD or the best treatments. In the past, we've been relegated to using sulfonylureas and insulin therapy. but we don't really understand whether or not these therapies are good for patients or whether or not they're associated with some risk. And so we're now starting to see some treatment trials in patients with CKD that should be very helpful. Also, patients with cardiovascular disease. There have now been 3 cardiovascular outcome studies in patients treated with DPP-4 inhibitors. The TICO study with sitagliptin, exam study with alogliptin, and the SABRE-TIMI study with saxagliptin. All have demonstrated there's no effect on MACE with the DPP-4 inhibitor treatment. Finally, another feature is people who need a convenient once-daily and well-tolerated medication would be a patient you might want to consider DPP-4 inhibitor therapy for. So let's turn to the next slide and talk a little bit more about the safety in detail. And what we're going to start with is the elderly population. Next slide, please. This is a special interest of mine because I'm trained as a geriatrician, and many of my patients in clinic are quite elderly. They have high prevalence of diabetes, as you know. In the U.S., the prevalence of diabetes in the elderly is about 25%, and another 50% or so have impaired fasting glucose or impaired glucose tolerance, and they're at risk for diabetes. So it's a huge epidemic in the elderly population. Unfortunately, we have very little evidence on which to base treatment targets or select treatments because the elderly have been systematically excluded from many trials. We know that the elderly are particularly susceptible to hypoglycemia. Now, the acute consequences of hypoglycemia, of course, include symptoms of sweating, irritability, confusion, but also include things that are important in the elderly like accidents, falls, and then things to counteract the hypoglycemia, such as inappropriate snacking that can lead to weight gain over the long term. Long-term complications of hypoglycemia include things like recurrent hypoglycemia because of hypoglycemic unawareness, poor compliance with the therapies because people don't like the feeling and they're skipping doses or, again, snacking. In the elderly, hypoglycemia has been associated with an increased risk for cognitive impairment and the development of dementia. And finally, from the ADVANCE study, the ACCORD study, and other studies, we've seen that severe hypoglycemia is associated with an increased risk for both cardiovascular events and microvascular events. If I could have the next slide. So you can see from a patient perspective that hypoglycemia could be a barrier to good glycemic control. It affects treatment adherence, people are skipping doses, and because of the impact on treatment adherence, then our opportunities to achieve goals are less. Also, hypoglycemia causes treatment dissatisfaction, and people who experience hypoglycemia with diabetes have much lower quality of life. So it's really something that we should try to avoid in our treatments for diabetes. I did want to point out that hypoglycemia with the DPP-4 inhibitors in general, and linagliptin in particular, is a very low event. In patients with monotherapy, initial combination with pioglitazone or as add-on to metformin, rates of hypoglycemia are under about 2 or 3% or so, and most of this, a vast majority, is very mild hypoglycemia. Now, the rates go up in patients who are treated with sulfonylureas as background therapy. And this doesn't actually reflect on the DPP-4 inhibitors. What this represents is the non-glucose dependent effect of the sulfonylurea on board. On the next slide, what we see is patients with treated with insulin and linagliptin. And what you can see from this slide is that there are no appreciable increase in risk for hypoglycemia in linagliptin-treated patients compared to people who are treated with placebo and insulin. So it's clear that patients with insulin treatment have more hypoglycemia than do patients who are not on insulin treatment. But the addition of linagliptin doesn't increase this risk for hypoglycemia. And it does significantly improve glycemic control. So even in your patients who are towards the end of the diabetes spectrum, we've seen that DPP-4 inhibitors like linagliptin are efficacious. Now you might ask, why is this the case? Because beta cell function is very poor at this stage, and that's why we need insulin replacement therapy. But I want to remind you that the DPP-4 inhibitors also work by suppressing glucagon. And it's probably this glucagon effect that contributes to the improvements in glycemic control in these people at the end of the diabetes spectrum. If I could have the next slide, please. Now, this slide is a slide that is a specific study done in patients above the age of 70. I mentioned earlier that there weren't many studies in patients who were elderly of diabetes treatments, but we've begun to see these with the DPP-4 inhibitors, and this is one of the best examples. In this study, patients who were above the age of 70 who had multiple comorbidities were enrolled in this study and randomized to either placebo or linagliptin treatments. At the end of the 24 weeks, the people on linagliptin had a 0.6% reduction in hemoglobin A1C. So just the same reduction you'd expect in a younger patient population. Linagliptin was very well tolerated in this patient population with no particular increase in adverse events. Next slide, please. And there were also very little hypoglycemia in this population. Now, people could be on a background therapy that included sulfonylureas. Overall, 24% of those on linagliptin and 16% of those on placebo experienced hypoglycemia. This is almost entirely due to the patients who had background sulfonylureas on board, which is kind of one of those middle bars there, where 30% of people on sulfonylureas and linagliptin experienced hypoglycemia versus only about 4% of the people who were on metformin with linagliptin, the next panel over. Finally, patients on insulin, as we've just seen, have higher rates of hypoglycemia, but this is not increased with the addition of linagliptin. Next panel, please. Now, I mentioned earlier that the metabolism of linagliptin is primarily by the liver and it's excreted in the bile, and there's no adjustment necessary for patients with chronic kidney disease. Now, I wanted to contrast that on this slide because chronic kidney disease is so common in the elderly. About 40% of patients who are elderly have some degree of chronic kidney disease. So with sitagliptin, we have to decrease the dose by half in patients whose creatinine clearance is less than 50, or half again in patients with severe end-stage renal disease. Saxagliptin, we decrease the dose by 2.5 milligrams if they're under 50. And then alogliptin is kind of like sitagliptin. We half the dose from 30 to 50, and again half the dose to 6.25 if patients have severe chronic kidney disease. So that's in contrast to linagliptin, where no dosage adjustment is necessary. Now the question is, how does linagliptin work in patients with renal impairment? Because this could be an important target. So that's shown on the next slide. This is a study in patients with mild, moderate, and severe chronic kidney disease in the three panels: left upper, right upper, and then the lower panel. What you can see across all of these groups is that the linagliptin-treated patients, who have the filled-in circles, had a nice reduction in hemoglobin A1C compared to the placebo-treated patients. And this was about the same that we see in other patient populations. Now, the number of patients in these groups is relatively small. There's a little bit of convergence toward the end of this 52-week study, in part because people had been dropping out because of other reasons. But the main point is that linagliptin was safe and tolerated in people with a spectrum of chronic kidney disease. Next slide, please. Now, this slide speaks to the safety and tolerability of the drug in patients with chronic kidney disease. You can see in the mild renal impairment, the left-hand panel, moderate renal impairment, middle panel, and then the patients with severe renal impairment on the right-hand panel, that there are very few adverse events in linagliptin-treated patients until you get to severe renal impairment. And even then, the prevalence of adverse events is quite similar to the patients who were treated with placebo. So the main message is that linagliptin can be used effectively and safely in patients with chronic kidney disease. Next slide, please. And this is just further emphasized by this table. Again, I won't expect you to memorize the table or ask you to fill out a test on the table. But again, the numbers are quite similar across the different degrees of kidney damage. Next slide, please. Now, the other question you might ask is, does linagliptin have any beneficial effects on the kidney? This provocative study that's published in Diabetes Care in 2013 suggested that there actually might be a benefit. This is a 24-week study, linagliptin compared to placebo, patients who had albuminuria. And what you can see is there's a significant reduction in the filled-in bars by about 20-30% or so in the urine albumin to creatinine ratio after 24 weeks. So it looks like there might be some benefit to DPP-4 inhibitor treatment. This could be related to glucose control, but of note, there are DPP-4 molecules in the kidneys as well as GLP-1 receptors in the kidneys. So there could be a direct effect of DPP-4 inhibition on the kidney. Next slide, please. Now, in the U.S. as well as around the world, the cardiovascular safety of DPP-4 inhibitors is very important, and the FDA, recognizing that, has required large outcome trials for all of the new diabetes drugs in development. And this really started with the DPP-4 inhibitors. There is a couple of ongoing trials with linagliptin, but those aren't completed yet. And so what we have are some data then from the other cardiovascular, from the other trials of the DPP-4 inhibitors. And what you can see in these trials is that without fail, all of the DPP-4 inhibitors, the relative risk or hazard ratio for cardiovascular events is well below 1. That's particularly true for linagliptin, which is the third line down. Of course, that doesn't always reflect the outcomes in the large cardiovascular outcome trials, so we look forward to seeing the results from the linagliptin trials. But my prediction would be that compared to sulfonylureas, which is one of the studies coming up, that there will be a benefit. Next slide, please. These are the designs of the 3 published cardiovascular outcome trials that I spoke of earlier, the SAVOR-TIMI 53 with saxagliptin, the EXAMINE study with alogliptin, and the TICO study with sitagliptin. The SAVOR-TIMI and the TICO study were quite similar to one another. They took patients with pre-existing cardiovascular disease or high risk, randomized them to the DPP-4 inhibitor or placebo, and then followed them up for 2 to 3 years. The EXAMINE trial is a little bit different. This study studied patients with acute coronary syndrome, and they were randomized to either alogliptin or placebo within 90 days of their acute coronary event. Next slide, please. You've undoubtedly seen these Kaplan-Meier curves for these 3 different trials, but I've lined them all up for you so you can see the consistency of results across the DPP-4 inhibitors. In each study, the outcome of MACE or extended MACE was identical to that of placebo. We're talking about hazard ratios of 0.99 or so. You can see then from these studies that there is no adverse event of DPP-4 inhibitors on risk for cardiovascular events. And it's true for saxagliptin, alogliptin, and sitagliptin. Next slide, please. And that's kind of broken down again in different formats here, where we have the forest plot. Again, you can see all of the point estimates lying right on the line of identity, and then a mean of the 3 studies also lying on the line of identity. So this again indicates no increased risk for MACE outcomes. No benefit, however, as well. Next slide, please. Now, the one thing that was different between these trials is that in the SABRE-TIMI trial, there was a significant increase in hospitalization for heart failure in patients who were randomized to saxagliptin. The mechanism for this is still not really understood, but it does not appear to be related to DPP-4 inhibition per se, because although there was a numeric imbalance in the examined trial, this was not significant, and in the TICO study with sitagliptin, there was absolutely no sign of any increased risk for heart failure. So perhaps there's something different about saxagliptin that relates to the different structure that I pointed out earlier. Because it's not related to DPP-4 inhibition, I would predict that this is not a concern for linagliptin. Next slide, please. This slide again presents some preliminary analyses that was published last year by Julio Rosenstock, which took linagliptin versus all combined comparators in all of the phase 3 clinical trials that have been done. These studies were all adjudicated cardiovascular events, so they align with what's done in a cardiovascular outcome study. And you can see that the point estimate for linagliptin, or the relative risk for cardiovascular events, is lower than it is for all of the combined comparators. Now, this period of observation is relatively short, only goes for about 2 years or so. We don't know what it will look like over the long term in the cardiovascular outcomes studies. Next slide, please. This, again, is a analysis of the different hazard ratios, risk ratios, odds ratios, etc. And you can see that they all lie to the left of the line of identity, indicating no increased risk, perhaps a little benefit for linagliptin. Next slide, please. But I've been hinting at the outcome studies that are ongoing. One is called the Carolina trial, which compares linagliptin versus glimepiride. That study is due to end in 2017. And of note, that is the only study in which a DPP-4 inhibitor is directly compared to an active comparator, in this case glimepiride. There's another study going on in which linagliptin is being compared to placebo that will be on par with all of the other CVOTs. So at the end of the day, at the end of 2017 actually, we'll have a much better idea about the cardiovascular benefits of linagliptin as it relates to other DPP-4 inhibitors and other products. So if I could turn to the next slide, please. This is the design of the Carolina trial. I mixed things up a little bit here, but as you can see, that's an active comparator trial, patients with type 2 diabetes with cardiovascular disease. Next slide, please. On the topic of safety, one of the important issues with the DPP-4 inhibitors and incretin therapies in general has been pancreatitis risk. And this has been extensively reviewed by the FDA and the European authorities as well as other agents. Keep in mind that across the 5, 6 different drugs that have been reviewed by these agencies, we have literally hundreds of thousands of patients on active treatment. The summary of the FDA and the European authorities is that the available evidence doesn't suggest that incretin-based therapies themselves increase risk of pancreatitis in patients with type 2 diabetes. Keep in mind that patients with type 2 diabetes do have an increased risk of pancreatitis. It's 2 to 3-fold higher than people without diabetes. And it's complicated if they have obesity, hypertriglyceridemia, gallstones, or other risk factors for pancreatitis. We should educate our patients about risks for pancreatitis, but I don't think this is a particular concern for DPP-4 inhibitors. May I have the next slide, please? So let's just close then with the discussion of the use of DPP-4 inhibitors in patients with type 2 diabetes. Just to remind you that these are oral therapy, generally once a day. They enhance endogenous GLP and GIP in response to meals, but these effects are transient over time. In doing so, they enhance insulin secretion and cause suppression of glucagon in a glucose-dependent fashion. This leads to clinically significant reductions in hemoglobin A1C that in other trials is comparable to rosiglitazone, and in 5 different trials very comparable, if not better than sulfonylureas. Because of their mechanism of action, they're complementary to many drugs that are already in the market. The exception here is that we should not use DPP-4 inhibitors with GLP-1 receptor agonists. And the reasons for this are quite simple. GLP-1 receptor agonists are also already resistant to the effects of DPP-4, so you don't get added efficacy per se. These drugs are very well tolerated. As I mentioned, this is the defining feature of this class of medications. They don't have any real GI symptoms, no weight gain. When used with metformin, there's even a little bit of weight loss, very low risk of hypoglycemia, and no edema or other concerns. We need to adjust the dose of these medications in patients with chronic kidney disease, except for linagliptin, as we've already discussed. They also have a very low risk of drug-drug interactions, so they're suitable for patients, and particularly elderly patients who are on multiple drugs for many comorbidities. And finally, there's largely a neutral effect of these drugs on blood pressure, lipids, and cardiovascular disease. So with that, I'm going to close my comments and remarks, and I would welcome at this point any questions from the audience. Thank you very much for your attention.